Okay, so hi everyone. My name is Dr. Al-Hashimi. I'm a recent graduate doctor, 2020, and I have a special interest in orthopedics. So today I'll be teaching you about orthopedic fractures. If you'd like to see some of my colleagues' lectures that they are producing, do click on any of the other videos on this channel. This is a short web mini-series consisting of 3 parts. This is the first part, so feel free to click on parts 2 and 3 to continue with this mini-series. If you are a medical student, sign up to the free S-Docs program, which you can do so from the link in the description to the video. Right. So what will we be covering today? Today, I'm going to split the lecture into 3 parts. The other part 2 and part 3 will be part of another video. The first part we'll be looking at today is the general principles of fracture classification, clinical features, investigation, and the management of fractures themselves. So, part 1. What is a fracture? A fracture is a loss of union of a bone or a loss of continuity of a bone. So if there's any disruption to continuity of a bone, we refer to it as a fracture. There are 3 key causes to any fracture. The first one being trauma to normal bone. The second being stress, so repeated stressful forces or low velocity kind of forces, which are acting on the bone, causing fractures. And the third one is disease. So to pathological bone. Examples of this would be osteoporosis, which is a state in which there is reduced bone density, particularly seen in elderly patients. Bone sarcomas, which are primary bone tumors, and metastases from other primary sites, such as prostate or breast, and Paget's disease of the bone. Right. So how do we classify fractures? So the way in which we classify fractures is there are multiple different ways, and there's no specifically set way. However, these are a set of examples in which orthopedic surgeons or other doctors generally tend to follow. So first one would be anatomical location and position. Second would be the extent of a fracture. Third would be the orientation of a fracture. Fourth would be displacement of the fracture. Fifth would be fragmentation of a fracture, and 6th would be soft tissue involvement, which we'll discuss further in just a moment. So to begin with, let's take a look at anatomical location and position. So we understand with every bone, generally the way that we refer, if we start looking at the anatomical model with a man with palms facing forward, is that we have proximal and distal. Proximal generally means closer towards the body, and as we move further away the body, for example, down the arm, or down the leg, we would refer to it as distal. So fractures can be classified anatomically based on location or position. So if we were to take a look at anatomical location of the bone, we would say proximal versus distal. Proximal would usually be within the first half of the bone. Here is a picture of the femur, and you can see that the proximal generally tends to go halfway along the diaphysis before terminating, or before that we start referring to it as the distal portion, which is the second half of the bone. Second one would be the second way in which we classify is anatomical position. So the way in which we generally tend to classify long bones is using 3 key terms: the epiphysis, the metaphysis, and the diaphysis. Diaphysis is the long shaft. Metaphysis is where the growth plate is found. This here shows the epiphyseal line in which the growth plate tends to eventually kind of fibrose and then form into an epiphyseal line. Then the epiphysis is usually what contains or constitutes as the head and the neck of the bone. And this is where the bone generally tends to form a articulation with another bone or a joint. Right. So the extent of the fracture. This is the second way in which we can classify fractures. A fracture can be classified based on its extent. So we have 2 types. We have a complete fracture, which is shown in this picture on the left, is that there is the entirety of the bone is being has been cut through or broken through, whereas incomplete, as shown here, is a fracture in which there is still portions of the bone which remain or maintain some form of union between both fragments. However, there is a disruption in the overall integrity of the bone itself. In terms of orientation of the fracture, fractures can also be classified based on orientation, so fractures generally tend on 3D, they are not 2-dimensional, and the way in which we generally tend to look at fractures is both from an antero-posterior view and a lateral view. So the way in which we can we can see fractures, or we can visualize fractures in a transverse way in which there is a horizontal based fracture, an oblique fracture, which basically means it is diagonal, going from further from the top to the bottom or vice versa. Spiral, in which the fracture generally starts to form in a spiralized shape. So you'll see fragments kind of hooking around each other like so. And longitudinal, which isn't shown in any of the pictures to the right, I'm afraid, but is a fracture which generally tends to span from the top downwards to the bottom. Right. Displacement of a fracture. So a fracture can either be displaced, non-displaced, and angulated. So a non-displaced fracture is a fracture in which the two key segments, which generally form a general union of the bone, are still in line with one another. A displaced fracture is when the fracture fragments are no longer in line with one another. So as you can see in this side on the right, you can see that both bone fragments are no longer in the same orientation, are no longer following the exact alignment in which the bone generally tends to follow, unlike the non-displaced fracture on the left, in which there is obviously some loss of union, or there is disruption to the uniformity of the bone. However, the angle and the orientation of the fragments generally tends to maintain, or it is generally similar to the original of the bone. Angulated. Sometimes we have fragments of bone which generally tend to form an angle from the general orientation. So as you can see here, not only is this bone displaced, however, there is some angulation as well, because the orientation of the distal portion of the bone is going at an angle as opposed to continuing with the general orientation that the bone generally follows. And here we have fragmentation. So a fracture can also be classified based on fragments. Butterfly fragmentation is shown on the left. The reason why we call it butterfly fragmentation is that we notice that these fragments here, as indicated by my cursor, generally tend to follow a butterfly wing kind of shape. A comminuted fragmentation is generally when there is a fracture which has caused multiple little fractures to kind of form along the length of the bone. It's generally referred to as a shatter in the bone. So you have multiple tiny pieces which are kind of dispersed within kind of the bone. Then you have segmental fragmentation. So segmental fragmentation would be a situation in which, similar to the one on the right, where there are multiple segments and there are two segments with a piece of bone in the middle, which is no longer attached as shown here. Now, soft tissue involvement. This would probably be one of the more important classifications that are important to know. So fractures may also be classified based on soft tissue involvement. We have closed fractures and we have open fractures. Closed fractures are generally known as simple fractures, in which there is no tissue and soft tissue involvement at all. The bone generally isn't massively displaced and therefore that does not interrupt any of the soft tissue nearby. However, open fractures generally result in disruption or angulation of the bone. The bone is no longer going in the exact orientation in which it should be following and therefore tends to penetrate the soft tissue. Therefore, it is known as an open fracture or a compound fracture. So classification of open fractures. Open fractures are generally classified using a system known as the Gustilo and Anderson classification. And this is a table which summarizes the Gustilo and Anderson classification. So grade 1 goes and spans through to grade 3C. Grade 1 obviously being the milder end of the spectrum, whereas 3C being when things are a little bit more serious. So grade 1 means that it is a low energy wound. Soft tissue involvement is less than 1 centimeter wide. Whereas grade 2, it is a greater energy wound greater than 1 centimeter, and there is moderate soft tissue injury involved. Grade 3 means that is usually a high energy wound in which there is a large portion of soft tissue injury, and there is obviously accompanying severe soft tissue injury as shown in the pictures from the middle throughout to the right. So 3A indicates that there is adequate soft tissue coverage. So despite the fact that there is an open fracture with the bone passing out through the soft tissue, generally what we tend to find is that the bone is more so, or the integrity of kind of the injured limb has some kind of covering or is encapsulated within the soft tissue still. 3B means that there is inadequate soft tissue coverage. So the bone generally has little to no protection. And 3C generally indicates that there is associated arterial involvement. So the arterial supply within the limb has also been damaged by the actual fracture itself. This is important not only for grading purposes or using for classifications, but also because it indicates severity along the bone fracture. It is important to remember that compound fractures are going to be more susceptible or more prone to infection is naturally due to the nature of these fractures being uncovered or more open. We would tend to be a bit more worried, obviously, about a 3B fracture in which there is inadequate soft tissue coverage and there is a high severity injury or a high energy wound, as opposed to a low energy wound, as indicated by grade 1. This is not to say that grade 1 is not serious. It is still an open fracture at the end of the day. So, what are the clinical features of a fracture? This is fairly straightforward. If you generally tend to think about a fracture, like we said before, is a loss of union. So if there's a loss of union, naturally what we'll see is that there will be a painful erythematous swelling at the site of the fracture. So there would be redness swelling along the site of the fracture itself. Deformity and axis deviation. So what we'd see is this kind of relates back to the angulation of the fragments of the bone. Fragments penetrating the skin. If it's an open fracture, you will see portions of bone passing through the actual soft tissue. A palpable gap. This is only natural as there is loss of continuity of the bone. And potential neurovascular compromise. If there is nearby structures, such as an artery, a vein, or a nerve, there is a chance that a fracture may cause neurovascular compromise. And this is when things are a little bit more serious. Going back to the Gustillo and Anderson classification, associated arterial involvement is potential, it constitutes or it comes under the umbrella of neurovascular compromise, and therefore is something that we need to be a little bit more mindful of. So how do we investigate fractures? So fractures are generally quite straightforward to investigate. X-rays, 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 always first line for all fractures. Generally, it is what is recommended. However, it's also important to remember that fractures are not 2D, they are 3D, and a bone is also a 3D portion of the body. So the way in which we should image fractures is that we tend to do an antero-posterior imaging, in which we take a look front to back, and a lateral as well, so that we can visualize the entirety of the bone in a 3D manner. So general management of fractures. So this is the general management pathway of fractures. Firstly, we'd like to start off with wound treatment. It's important that we start off with wound treatment because there may need some form of debridement around the site of injury. Pain management. We're not going to keep the patient in pain. One of your key jobs as an F1 doctor is going to be pain management. So this consists of both opioid and non-opioid analgesics. Examples of opioid analgesics would be things such as codeine, tramadol, dihydrocodone, etc. Non-opioid analgesia would be taking a look at things such as non-steroidal anti-inflammatory drugs, such as ibuprofen or celecoxib, which is more of a COX-1 inhibitor. So fracture care. So it's conservative or surgical. So generally what we tend to find is that there is three stages for fracture care. The two key stages are anatomical reduction and surgical fixation. So reduction is the process in which we bring the two fragments or the two pieces of bone closer back together. This can either be done in an open manner or a closed manner. An open manner generally indicates that there has been an incision made and we are surgically exposing the bone fragments in such a way that we are able to bring the two pieces closer together. Before we tend to do fixation, we generally tend to do reduction by bringing the pieces back together first. Closed can be done by bone manipulation without surgery. If you go and take a look at any orthopedic surgery, or if you've gone and looked at orthopedic surgery in the past, what you'll notice is that some surgeons tend to opt to not do open reduction and can opt to do things such as closed reduction, and by manually manipulating the pieces of bone and bringing them closer together. Surgical fixation is either internal or external. External indicates the use of frames to stabilize the bone, as shown on the right, whereas internal means that we are using methods such as plates or screws within the bone to stabilize it. So this on the right is known as an Ilezerov frame. It was a technique pioneered by Ilazarov, and it's a process which involves using forces and stresses on bone to regrow bone by providing a scaffolding structure around the actual bone which is damaged. What you'll see here is pieces of sponge. What's below that would be pins which will be attached directly to the bone itself and then covered so that to reduce infection. What you generally tend to find is that there is a risk of infection in these kinds of patients, as you are, especially if it's cutaneous infections. Immobilization. So all fractures should be immobilized during the proximal, including the proximal and distal joint. So if you have a fracture, for example, along the forearm, you would want to immobilize the wrist and also immobilize the elbow. Carefully monitor neurovascular status following immobilization. It's always important to make sure that there is no arterial, venous, or nerve injury. It's more important. It's more serious when things involve arterial or nervous injury. And then finally, to conclude, would be tetanus prophylaxis, which is which is usually recommended. Now, there are specific additional measures for open fractures generally. So broad spectrum antibiotics. This is to target any bacteria which may cause an infection and may cause permanent destruction to the bone. We need to make sure that it's thoroughly debrided, and open fractures generally should be debrided and lavaged within 6 hours. Class 3C, as mentioned prior in the Costello and Anderson classification, where there is arterial involvement, usually needs an amputation if not managed correctly soon. It usually involves input from vascular surgeons prior to orthopedics. Thank you very much for watching part 1 of my series. This is focused generally on fractures, classification of fractures, investigations, clinical features, and general management of fractures. Part 2, we will be looking at examples of eponymous fractures.